ugly things that we do outwardly. Sexual orientation actually includes attraction, behavior, and sexual identity, but it doesn't include gender identity or gender expression. And that distinction is important because, there's a misconception that all trans people are gay or lesbian or, an extreme gayness, which is, misinformation. And these two little penguins are the Canadian penguins that they fell in love with each other, and then they were separated, and they both went into depression. So they brought them back together, and this is a picture of their reunification. They're two men, two little boys. So just as a working definition, and this is ongoing, it's like open for transformation within our own community, but just to be able to talk about transness, the term transgender is loosely defined as an umbrella term used to describe people whose gender or gender expression is different than the sex they were assigned at birth. So I also wanted to talk about the epidemiology that exists, just to contextualize what's happening currently in our country around trans people. I like to show this slide because there are so many different identities, and these, am I breaking up? I saw someone. Can you hear me okay?
I can hear you fine, Danielle.
Okay, maybe it's their connection. Thanks. So in this slide, there are actually terms from indigenous cultures. And in indigenous cultures, trans people were often seen as healers, shamans, and people that were very special and were looked up to. And those terms go across indigenous cultures, and it's only in our modern day society that we're experiencing so much transphobia. I wish we could get back to that place of remembering our sense of place. We face multiple barriers to healthcare, and I want to talk about those. So the challenges in data collection is that there are no population-based studies yet conducted. There was one that was a landline study, but not very many people have a landline. And so what they did was they asked people, how many of you identify as trans after they gave a description? And those that said yes, they included it, and those that said no were not included in their data. But it was very limited. There's lack of gender variance variables in health surveys. There's so much social stigma that for trans people to really feel comfortable disclosing their identities that system is not really in place yet, and we need to build that together. This idea of post-transsexual identity through pathology-based models, we've been encouraged to assimilate into the gender binary, which is male and female. So many of us, for safety reasons and because of the internalized pathologization of trans bodies and experiences, will go into this stealth mode. And the data is currently pretty trans female-centric, and that has to do with the prevalence of HIV amongst the community. There's trans male invisibility, which really speaks to the social stigma that exists. A lot of trans guys don't feel comfortable disclosing their identities. There's also post-transition kind of stealth existence as well. And the real difference is that the pandemic of HIV has really impacted trans women. So a lot of the effort has been put forth to decrease risk and keep people in care. And as I said before, it's really all pathology-based. So we need to do a better job of looking at collecting data for our community. So there was this meta-analysis done by Barral et al., and it was around 15 countries, the U.S., 6 Asian Pacific countries, 5 in Latin America, and 3 in Europe, 11,000 66 transgender women were a part of this meta-analysis and the research, and it was estimated that the HIV prevalence was 19.1%. The odds ratio for being infected with HIV compared with all adults of reproductive age across the countries was 48.8. So it's pretty high, very sobering, and trans women are less likely to have access to and utilization of HIV services. So when we look at North America, there's a 28% HIV prevalence among trans women. And it's interesting that there's a difference between self-report and actually confirmed trans women living with HIV, because that says we're not doing a good enough job of testing trans women and getting them into care. And the most recent research that we have around trans men and HIV prevalence shows that there's a 0 to 3% prevalence. So when it comes to barriers to healthcare, there was a wonderful study done by the task force and NCTE with over 6,000 participants. It's the largest study to date. 28% of their sample postponed necessary medical care when sick or injured. 19% were refused care due to their gender identity. 28% were subjected to harassment in a medical setting, and 2% were victims of violence in the doctor's office. All of this data is so sobering, and we have a lot of work to do. When we think about 50% reported having to teach their medical providers about trans healthcare, and 1% reported being attacked in the emergency room. And, you know, it's no wonder that 33% delayed or did not try to get preventative health care. It's kind of a scary system to walk into for us. And just to contextualize this, it's really important to think about this, this kind of this context, and to think around trans communities and all of the intersections we have in our lives, and move away from pathologizing our behavior and our experiences, and talk about how transphobia has really oppressed us and put us in a position where we're really looking to survive. So when we look at social determinants of health, it's important to think about those contexts and incorporate them into our programs. So here are some best practices that I would like to share with you all around HIV prevention for trans people, and I have some for healthcare. So one, grounding your work in the community, and that means actually hiring trans people to work in agencies. And one size does not fit all. We need to really think about the communities we're approaching and get their perspectives incorporated. Our perspectives as trans women are really important to include in any programmatic effort. Otherwise, we fall short from providing the services, and people don't see kind of their own kind in the services. Using multidisciplinary approaches, so thinking about the different policies that exist and thinking about changing those systems and advocating for those changes. And getting the facts, really understanding and having perhaps a community advisory board doing formative research to understand the community and how to develop programs. And trans people, especially high-risk trans women of color, are usually able to be reached outside of the window of traditional 9 to 5, time. So, for example, a clinic locally, Tri-City Health Center, the Brandy Martell Project, they do outreach like at 1, 2 in the morning, and they'll go to the place where trans women are actually doing survival sex work. They'll go to their hotel rooms, they'll bring their test kits, and they'll engage them in their services. And increasing access to health care is really important. We're hiring trans people. Let's think about how we can provide them health insurance that covers gender-affirming health care, and also advocating for linkages between your organization and clinics that are trans inclusive. And staff development is also very key. It's important to create opportunities for your staff to engage in training and also to, sorry, I got distracted by the messages, to engage in training and also to have opportunities for growth internally, especially for trans employees. And so that's actually going to reflect to the community. There's hope for me. I can actually raise in the ranks and be a professional in life, which, you know, some people want to, some people don't, but it's a wonderful thing. And advocacy, and I've talked about that throughout these slides. So trans-affirming healthcare is so critical. Training all staff, including reception, medical providers, maintenance, and security. Usually we fall short when, you know, we come into a clinic and security is like harassing us or checking us out or behaving in a way that's not sensitive to our needs. So it's really important that all staff be trained in trans-affirming healthcare. On our website, you'll find primary care protocols for transgender patient care. Utilize them. It's so important to use those protocols. It's the first of its kind that's vetted by a medical university, and they're on our website. It's really important to provide trans-affirming healthcare, and something we, our capacity building assistance branch developed in partnership with the CDC and other organizations, the first National Transgender HIV Testing Day. So ramp up for next year, make your plans, and really incorporate this effort to get trans people tested and get trained on how to conduct sexual risk assessment surveys. Also incorporate the two-step data collection recommendation. It's available on our website. And first we're asking, what is your current gender identity? And then followed up with, what sex were you assigned at birth? We also have a free course online, and this is titled Acknowledging Sex and Gender. It talks about the two-step data collection recommendation and how to make your environments more welcoming for trans people. Here are some good treatment practices: using proper pronouns with all clients, get clinical supervision if you have issues or feelings about working with trans individuals, accommodate trans clients' desires and needs to continue the use of hormones or not. Not everyone wants to use hormones. Guide trans clients using street hormones to obtain competent medical care instead of barring them from accessing hormones, really supporting them and checking their blood work to make sure they're okay. We have additional resources on our website. They're listed here. You're welcome to check them out. And I'd be happy to answer any questions and also, discuss any feedback you have.
Thank you for that wonderful presentation, Danielle. We will have a Q&A session at the end, so if you have any questions, please submit them in the chat box, and they will be included in our list for presenters at the end. And now we would like to turn it over to Allison Gill.
Thank you so much, Ryan. Hi, this is Allison Gill. I am a senior partner with the Parallax Group, which is a trans-led consulting firm focusing on organizational capacity building and advocacy and policy strategy. And I'm going to be talking about both the DC Cultural Competency bill that was passed this past year, and also cultural competency and its importance for serving trans and LGBT patients in general. So first we're going to talk about why is cultural competency important for LGBTQ healthcare, and talking about health disparities, then discussing the expansion of trans coverage and lack of knowledgeable providers, and then we'll discuss in a little bit more detail what the new DC law does. And I should mention the new DC law is the first in the country, which requires cultural competency training for healthcare providers, which is why we're discussing it in some detail. Okay, so what is cultural competency? So in essence, cultural competency is a set of behaviors and practices that allow professionals and systems to adequately serve people across difference. And, the difference we're talking about here is primarily around sexual orientation and gender identity. Here are a few definitions that are used in various types of research from several papers to give you an idea. Cultural competency is a really important term in professional circles and especially in medical and healthcare professions. And so I know Danielle spoke about health disparities a little bit with regard to LGBTQ populations, but I wanted to just touch upon a few more items here. So we know that LGBTQ people face increased rates of HIV and other STIs, depression and drug use and suicide, and also victimization and intimate partner violence. And as we discussed, this really is a result of both minority stress and also systematic discrimination. In addition, cultural competency is really critical to help us address these issues by improving access to systems that reduce risk and allow these people to get adequate and informed health care. So we see that trans people are less likely to receive necessary medical screenings, more likely to engage in self-treatment or medication, and less likely to seek medical or mental health care. These are all areas where having more culturally competent, clinically competent service providers can make a real difference. If trans people have negative experiences when they engage, when they seek out healthcare, then they're more likely to avoid healthcare screenings or, self-medicate in the future. If they have better experiences, they are less likely and more likely to seek out healthcare. In addition, studies show that there is a definite lack of training that has a direct impact on LGBTQ patients and LGBTQ healthcare. For example, there is an Institute of Medicine report from 2011 that noted the lack of structural behavioral results from providers' lack of training on the healthcare needs of LGBTQ patients. In addition, there was a terrific survey done by Lambda Legal in 2009, which looked at healthcare among LGBTQ patients and shows in a number of areas where they, face disparate rates of being refused care, having professionals refuse to touch them or speak to them in abusive ways, and have other sorts of negative outcomes. The Government Healthy People 2020 initiative also describes the shortage of healthcare providers who are culturally competent in LGBTQ healthcare. They noted a shortage and a lack of adequate training in this area. There's other examples of research that demonstrates that there's been insufficient training in medical schools and also in the field regarding LGBTQ health. For example, an academic study from 2015 found that only 4.4 this is a study at academic facilities, only 4.4 had a policy to identify LGBTQ competent physicians. Only about 16% offered comprehensive LGBTQ competency training, and more than half had no LGBT components in their training at all. Moreover, there was a study done among deans to assess their level of LGBT cultural competency in their own medical schools and professional schools, and 70% of those surveyed rated their school's curriculum as fair or worse in this area. So I think this was even recognized among the people providing and training new medical professionals in this area. So I think the questions are, how do we address this? And yes, over time, more healthcare systems, more medical schools and other trainers will slowly change to include more LGBTQ healthcare. But how do we address more broadly the providers in the field, the millions of healthcare providers that already went through their initial training and need to serve the LGBTQ patients in their daily practice? So this slide is compiled from a number of different research sources, and I'll provide that to Ryan so that he can send it out to you all. But it's composed from a number of qualitative analyses and follow-up after various different LGBTQ training programs and cultural competency programs, and shows that, yes, this training can make a real difference, both to make providers more comfortable serving LGBTQ people, decrease discomfort when asking questions that are really essential for LGBTQ people to understand their health issues and, put them in a better position in general to serve LGBTQ patients. I'll just note that there has been, over the last couple of years, an increasing level of coverage of LGBTQ healthcare, especially for trans people. However, the training for medical providers has just not kept up. Currently, DC is one of 16 jurisdictions that include insurance coverage that require third-party insurance to cover medically necessary transition-related care for clients. And this is a rapidly increasing number. Just a few years ago, it was just 10. So over the past few years, I think there's been 6 new jurisdictions to add this requirement as far as insurance providers. Moreover, the Affordable Care Act and many states have non-discrimination laws in place that apply to medical providers that cover LGBTQ people. And finally, more states are explicitly expanding Medicaid to provide trans-inclusive coverage, so saying that state Medicaid coverage includes medically necessary transition-related care and also providing trans-inclusive healthcare benefits for state employees. So we see that coverage is increasing on a variety of different levels for LGBTQ folks, but especially for transgender people. However, this increasing healthcare coverage has not necessarily led to an increase in access or quality of care. Few providers are trained in transition-related surgery, and many of those providers don't take insurance. There's no accreditation currently of training for trans-related medical services, nor is there certification of expertise in trans medicine. And the standards of care produced by WPATH for trans healthcare are not binding on medical providers. And finally, there are a number of obstacles to payment for trans-related services, even if there is coverage in the first place. So the bill I'm going to discuss in a moment is not a solution to these issues, but it is a step in the right direction, a step to help people receive training, especially for those practitioners who are already in the field. So with that, I'm going to switch and talk to the new DC law that passed last year and that's coming into effect at the end of this month. The DC LGBTQ Cultural Competency Continuing Education Amendment Act, and I know that's a mouthful, requires any existing continuing education requirements for licensed clinical healthcare providers in the district. So those are people that are required to be licensed by the district and are also required to have continuing education requirements to include 2 credits of instruction on cultural or specialized clinical training focusing on LGBTQ patients. So just a few clarifications. This operates based on the licensing cycle of the profession and does not require any additional continuing education credits. So let's say you're in a profession that has a 2-year cycle and it requires 30 credits. This would require that 2 of those 30 credits must relate to either LGBT cultural competency or specialized clinical training focusing on LGBTQ patients. The various different licensing boards for each profession define what is appropriate instruction in these areas. It's not imposed by the law. It's defined by the medical professionals, just like every other training is approved by the relevant professional boards. And non-clinical practitioners and professions are exempt. So, for example, if we're talking about a social worker who does not actually see patients and is non-clinical, they would not be required to comply with this new law. So I included here a few of the example trainings from the language of the new DC law. These are not required. It's just to give an idea of things that could be included under the training. And the training, criteria are fairly broad. We're talking about any sort of LGBT cultural competency or specialized clinical training for LGBTQ people. And so you see some of the things here include health disparities and risk factors, ways, best practices for making sure that support staff are receptive and treating LGBTQ patients appropriately, looking at intersectional issues between LGBTQ folks and those communities which face increasing various different types of oppression, such as racism or disability, for example, and ways to address underlying cultural biases that prevent appropriate care that may result in discrimination against people who identify as LGBTQ. So these are just some informative examples. As I said before, it will be up to the individual professional boards to approve trainings in this area for the new law. Okay, so what comes next? I just want to note, first of all, that the bill defines LGBTQ pretty broadly. It's saying that it includes patients who identify as lesbian, gay, bisexual, transgender, gender nonconforming, queer, or question their sexual orientation, gender identity, and expression. So that's a fairly broad definition because we want to make sure that everyone is included. In DC, this law affects 33 licensed healthcare professions. And I get asked the question frequently, well, why do we need to cover everybody? Can't we just cover doctors or nurses, et cetera? But, the fact is that every LGBTQ people seek out healthcare in every area, from ophthalmology to, podiatry, right? So I think it's important. And, when drafting this bill, we thought it was really important that we cover the entire spectrum of healthcare. So this bill is significant in that it's not only the first LGBTQ-specific, cultural competency training requirement, but that it's fairly broad in application. At the next stage, the District Department of Healthcare will need to issue regulations, and also the professional boards will need to approve qualified training. And I also get asked a lot, is this effective? Do we know if this will work? So that's a great question. In New Jersey, passed a mandated cultural competency training for physicians. It was not LGBTQ specific. It was a broader cultural competency training requirement. And the HHS Office of Minority Health, which provides some of that cultural competency training, saw after this law came into effect, within 1 year, a nearly 60-fold increase in the amount of physicians reaching out for training. So just a vast amount of additional outreach and training occurred relating to cultural competency when this requirement came into effect. And I hope we see the same in DC so that this training becomes widely available. And finally, I'll just note that Ryan will talk about this at the end, but there are free resources available from various organizations to provide this sorts of training. For example, the LGBT Health Coalition, the Human Rights Campaign, the National LGBT Health Education Center all have training in this area that's available widely and also online. And with that, I'll pass it back to you, Ryan. Thank you.
Thank you, Allison, and I will detail some additional resources at the end of the activity. And now I'm going to turn it over to Omar.
Thanks, Ryan, and thanks everyone for being part of this webinar. And so I'm a staff attorney for Orlando Legal. We are a legal organization that's been advocating on behalf of LGBT people and people living with HIV for over 43 years. And we do that through impact litigation, policy, and education. So what we're going to be discussing today is about the legal tools that we have available to address discrimination against transgender people in healthcare settings. In so doing, we wanted to discuss what are the issues that are faced. Some of these have been able to discuss by Danielle and Allison, so I'll go briefly through them. And then what are some of the legal tools that we have available both federally and at the state level. So some of the issues faced by transgender people in healthcare includes barriers to healthcare, discriminatory treatment by healthcare professionals, the denial of sex-specific medical care, and the denial of coverage for gender transition-related healthcare. So what are some of those barriers that are faced by LGBT people, in particular transgender people, with regards to healthcare? One of them is limited income and the fact that LGBT people are underinsured being compared to the general population, and transgender people are uninsured and underinsured to greater extent when compared to the population at large. There's also a lack of trained professionals, as Allison was discussing, with regards to cultural competency with regards to LGBT healthcare. And there's also a lack of access to mental health services. For example, when the legal did the survey when healthcare isn't caring in 2009, and over 51% of transgender and gender non-conforming people responded that they believe that there were not enough mental health support groups, and 59% believe that there were not enough substance abuse providers with specific knowledge with regards to transgender issues. Likewise, with regards to the lack of cultural competency, nearly 9 in 10, 89% of respondents said that they did not have healthcare professionals who were adequately trained to care for transgender and gender nonconforming people. In addition, transgender people and gender nonconforming people face greater rates of discrimination. 70% of transgender and gender nonconforming people reported experiencing healthcare discrimination or harassment when seeking healthcare in our survey in 2009, and those rates were even higher where the transgender people were people of color. This includes inappropriate behavior for medical professionals, whether it is a refusal to treat or also inappropriate questions, and having them misidentifying their gender, misidentifying their name, and not respecting their gender identity. It also involves the denial of emergency medical care. So getting into some of the specifics, there is both a need for sex-specific medical care that all of us have, and regardless of our gender identity. There are systemic problems that are posed with regards to gender markers and insurance coding, that when somebody is entered as one gender, whether it was the sex assigned at birth, but they identify as another gender, their ID documents have the correct gender marker. This poses a problem when they're seeking specific care, whether it is a prostate exam or whether it has to do with going to an OBGYN. And there's a denial of both preventative care as well as treatment of specific sex-specific care. Here you have a picture of Robert Eads, the subject of the Southern Comfort documentary in 2001. He sought care for ovarian cancer and was denied by over a dozen doctors. Ultimately, he was denied by so many that by the time he found a medical provider willing to treat him, the cancer had metastasized, and he later died of that cancer. There's also a need for gender transition-related health care to be covered. Multiple medical organizations have already, there's a broad consensus that gender-affirming care and gender transition-related care is an important part of the treatment of gender dysphoria. This includes hormone therapy, gender-affirming surgeries. Yet many medical healthcare providers and insurance companies continue to exclude this coverage or deny this medical care, and that is something that we have been addressing, and we'll talk a little bit about Section 57 and how that takes care of that. So one of the major tools that we now have available is Section 1557 of the Affordable Care Act. This is the non-discrimination provisions of the healthcare reform. In September of last year, the Health and Human Services Office of Civil Rights released the proposed regulations. And in them, it specifically states that Section 1557 prohibits discrimination on the basis of sex in any health program or activity covered by the Affordable Care Act. And that is defined quite broadly. Essentially, if you're a medical provider or a hospital and you accept Medicare or Medicaid as a form of payment, you are covered. If you receive in any way a grant from the federal government related to health, from HHS, you are covered. And in the proposed regulations, the HHS made entirely clear that on the basis of sex is explicitly defined to include sex stereotyping and gender identity. It is important because this applies quite broadly. All of the health insurance plans that are covered on or available on the healthcare marketplaces are covered under this provision. Most hospitals are covered under this provisions, and this therefore has a broad applicability. Likewise, other federal laws like Title VII with regards to employment and any employer health provider plan, and Title IX with regards to education that prohibit discrimination on the basis of sex have been interpreted to include prohibition on discrimination on the basis of gender identity. And this is something that has been found by the Equal Employment Opportunity Commission, the Department of Education, and the Department of Justice. And multiple courts have now affirmed those readings of the federal agencies of the statute. So what are some examples from enforcement of Section 56.7? Obviously, this is a relatively new law, federal law, but we've already seen successful enforcement of this law. One of the first cases under this section includes Rumble v. Fairview Health Services, in which a transgender teenage boy went to obtain medical care at a hospital due to a urinary infection. Not only was he misidentified and given a bracelet that identified him as female, he was also mistreated, had to wait hours in a waiting room for a doctor to treat him. And when the doctor came, the doctor acted in a hostile manner, asking inappropriate questions, and providing inadequate treatment. They filed a complaint in federal court, and the court refused to dismiss the case, and specifically said that Section 1557 protects plaintiffs who allege discrimination on gender identity. This is quite important, and it's a big victory that occurred just last year about the broadness of Section 57. This even occurred before the issuance of the proposed regulations from the Department of Health and Human Services. Likewise, we have an enforcement action by the Department of Health and Human Services where they entered into a voluntary resolution agreement with Brooklyn Hospital Center in New York. In that case, there was a complaint filed with HHS in which the hospital had placed a transgender woman in a room with a male patient there, and treating that patient as if she was male. In so doing, there was a complaint filed with the HHS, and HHS did a appropriate investigation and entered into a resolution agreement with the hospital where they adopted a number of changes to both their intake the inter-process forms and how they will place patients and treat them with regards to their gender identity. Because it was a voluntary resolution agreement, there was no admission of fault, but it was a big, important first step on the enforcement of Section 57. We also have legal tools available at the state level. To the extent that the federal law may be inapplicable in one instance or another, it's important to know that 70 states and the District of Columbia prohibit discrimination on the basis of gender identity in public accommodations. That typically includes hospitals, private hospitals, medical providers, and even insurance companies. In New York, specifically, while not explicitly spelled out on the statute, New York has interpreted its regulation, its statutory provision on sex to cover discrimination on the basis of gender identity and it just issued a final rule a couple of weeks ago. Finally, and as mentioned by Allison earlier, we have the state insurance bulletins. 15 states and the District of Columbia have issued regulatory guidance to insurance companies prohibiting discrimination on basis of gender identity in health insurance policies and contracts, and you have a list of the states there. These regulatory guidances are actually based on a wide array of statutes and laws and regulations. They include from the Affordable Care Act to the state's own non-discrimination laws to mental health parity laws and so forth. And they therefore make illegal any insurance exclusion, which is also illegal under the federal law with regards to coverage of transition-related health care. They have actually proven to be quite helpful. We actually represented a young transgender boy who was denied gender-affirming top surgery by one of the national insurers in his mom's employer-provided health insurance plan because they had an explicit exclusion. Once we pointed out that that was contrary to the insurance bulletin issued by Connecticut, the insurance company then issued a second denial based on saying that the treatment was not medically necessary. Not only did we use the insurance bulletin as proof of their discriminatory treatment, but then we filed an external appeal, and the insurance company was ordered by the state to cover the gender-affirming surgery for this patient. So there are multiple resources available, and we at Lambda Legal have a trans toolkit. You have the link there that includes a lot of information with regards to healthcare, transition-related care, and medical professionals, as well as other settings, whether it's employment or education or public accommodations in general. And we have a number of publications that are quite helpful, including our When Healthcare is a Caring survey, Healthcare Rights and Transgender People, Medicare Benefits and Transgender People. And then we also have published, along with the Human Rights Campaign and the New York City Bar Association, a transgender-affirming hospital policies and a model that is now being used by multiple government agencies as well as the Federal Department of HHS. In fact, those policies were part of the Brooklyn Hospital Center agreement. So with that, thank you so much for participating and for being part of this webinar.
Thank you, Omar. And now, last but not least, I turn it over to Anand.
Thanks so much. I'm really glad to be here, as others have said. I'm so glad that we had the lead up from Danielle and Allison and Omar to talk about the bigger picture issues and the cultural competence issues that many people are experiencing, and to make sure that we're all having a shared understanding of what the situation is. I just have a few slides that I want to go through that will help walk you through the particular situations that many of you as healthcare providers or caseworkers or support staff in clinics and hospitals might be experiencing, particularly about how we can turn these laws and policies that we've been hearing about into practice. So let's go right into it. I'm actually going to skip this. Well, I'm going to focus actually on the bottom two. So we've heard already about kind of barriers to care being around denials of private insurance and exclusions in healthcare plans. Particularly what I'm going to focus on is how do you navigate that bureaucracy once you or your clients have health coverage, and what do we do about this shortage of educated or educated in-network providers? These are the things that remain when we have good policies in place. We still have these barriers to go through. And as we've already heard about, we have gotten these non-discrimination bulletins from 15 different states plus DC, and that what this does is it tells insurers that are selling insurance in the state that they're not allowed to discriminate based on a number of different categories, including gender identity and often gender expression as well. The scope of that, I think Omar covered really well, and Allison did too, so I'm not going to say anything more about that. So what happens when we try to implement these policies? Well, different things pop up. One is that there might be new exclusions that pop up. So whereas before there would be a blanket exclusion for all transition-related care or things like that deep in the documents of the health insurance plan, now the situation is that the insurers will try and kind of wiggle out of their responsibilities and will try and create kind of arbitrary limits on what types of procedures should be covered. So they'll label certain things as being cosmetic and therefore not medically necessary. Or there will be the situation where the insurance the insurance plan theoretically covers transition-related care, but there's nobody in the network who can provide that care. And this is particularly a problem in rural areas. And then the cultural competency issue comes down to a lot of different things. For example, with humans, because we're the workers who are implementing all this stuff and trying to give people health care and all that. There is insufficient cultural competency training, and a lot of this is because there's a lot of competing priorities, as I think you all know, in terms of, how are we going to stay up to speed, and if you're in a community clinic situation, if it's not actively on fire, it's hard to devote resources to that particular issue. So, things like maybe one or two medical providers will get training, but not the frontline staff or not the billing staff. And it really takes everybody having the same understanding and knowledge of who transgender people are and how to work with transgender people in order to make sure that the experience from start to finish is affirming. And then in the system, so in things like electronic health records and in the computer systems with insurance companies, things don't get changed to keep up with the fact that that practicing non-discrimination means providing affirming healthcare, and all those little details often get skipped over. So I want to switch over now to thinking about things in kind of a bigger picture. This is a model that I use in trainings that I usually spend a lot more time on, so I will be brief today. But what we're seeing here is that each of these blobs represents a particular player in the healthcare system: government healthcare providers, patients, pharmacies, and insurance carriers. And what I'm focusing on today is what I call the patient-provider-payer triangle. So when we're talking about discrimination and we're talking about insurance noncompliance or insurance just rudeness generally, most often what it comes down to is what's passing back and forth between healthcare providers, insurance carriers, and patients themselves. So this may be a bit of review for many of you who are, already healthcare providers, but just very quickly, every time a patient comes in, there's an exchange, right? So they receive healthcare from you, right? You prescribe medicine, or you diagnose things, or whatever the particulars may be, and then in return, they'll pay you a copay if they owe one, or things like that. Then the provider's office sends over a claim to the insurance carrier that includes a list of every procedure that was done during the visit and a matching diagnosis code. And then if everything works out, then the insurance carrier will send back a check to the healthcare provider, and they'll send an explanation of benefits to the patient as well as a copy of that to the healthcare provider. And that explanation of benefits will say on it what their allowed amount is for paying for each of those treatments, and how much they paid and how much the patient owes. If there is a mismatch, however, they will issue the explanation of benefits will say that they are paying zero, and that is what we call an insurance denial. On the next slide here, I just said that part, excuse me. So the problem comes in here when people get these insurance denials in hand. So over the last couple of years, we've seen non-discrimination in health insurance for transgender people just shoot up from 0 states at the beginning of 2012 to 15 states plus DC now. So just over the last 3 or 4 years, things have changed dramatically. Whereas before, it was almost unheard of for a transgender person to get coverage through their health insurance for transition-related care. Now it is more and more becoming people's expectation that this will work. And what is not changed in the meantime is a lot of these kind of behind-the-scenes things that make this process, this triangle, go smoothly. So when patients are coming to you and saying, my insurance is supposed to cover this, but they told me it doesn't, or I got a denial, or I don't know what to do, this is really where things where it comes down to. So if you're working in a provider's office and you're a patient care coordinator or a peer navigator or a case manager or anything like that, often it's going to come down to you to help the patient figure out what they can do when they are in this situation. It's really important to know what the law is and what the policies are in your particular state, or sometimes at the local level there are particular provisions, because this can shake out a number of different ways based on the type of payer, whether it's a public or private, whether it's a managed care or a self-funded plan, whether it's an HMO or a PPO. The rules can be different depending on the particulars of the situation. And so in order to really make sure that you're able to get that patient through the hurdles and through the barriers that the insurance company is now throwing up, it's really important to know what type of plan they have, who the regulator is for that plan, and what claims you can make. And it's really important that a denial has occurred in writing. So very often we'll hear from people through our helpline saying, I tried to get my hormones covered and they denied me, but what may have actually happened is they talked to the customer service representative at the insurance company, and that person said that transition-related care was not covered, even if that wasn't actually true. The problem with that is that while it's very frustrating and confusing for the patient, it doesn't actually constitute a denial because there's no kind of actionable thing from this conversation that happens over the phone with the customer service rep. This is a really common situation. So what is the best thing to do from a provider perspective is anytime you have a patient who's seeking any type of transition-related care, whether it's hormones or surgery, or often even just gender-specific care like a pap smear, prostate exam, breast exam, I highly encourage everyone to do a pre-authorization with the insurance, which is basically you submit the claim ahead of time before any cost has been incurred, and then the insurance will send back the equivalent of an explanation of benefits, where they'll say this is how much we would pay, or no, we won't pay this. If they say no, we won't pay this claim, they're required to give you a reason for it, and they might say this care is excluded from the coverage plan, or they might say this is cosmetic, or they might say we don't pay for any claims with this diagnosis code, and there's a lot of different combinations that this can bring up, but the key thing is that if you know that you're in a state where there is statewide non-discrimination, or pending these Section 1557 regulations in a couple of months from now, and you're getting one of these kind of denials, or the patient's getting one of these kind of denials, you should know that they're generally doing whatever they can to avoid their responsibilities. And, it's just in their financial interest to do so. So it might sound a little bit pessimistic or skeptical for me, but that has been my experience. So often they are banking on the fact that patients don't know what their rights are, and so they'll just say no automatically because they're used to being able to say no. And what really needs to happen is you just need to do a first-level appeal within the insurance company. And often, I don't want to throw a number on it, but I would say more times than not, that first level appeal is successful, and you don't have to escalate, and you don't have to sue, and you don't have to, really go very far with that. If that fails, you can do a second level appeal. And this is where the insurance bulletins that Omar was talking about are so helpful, because what those do is they give people access to the state appeals channel. So you can request an independent medical review, for example, through the state Department of Insurance or whatever the particular department is called in the particular state, which then can compel the insurance carrier to overturn the denial that they had previously issued. It is, it can be an onerous process, and it's not really fun for anybody, but it is better than what we had before, which was just that you were kind of SOL if you got an insurance denial. Just want to check over here. Okay, so for an example for folks who aren't familiar with this, how does this work? If you submit a claim to the insurance company that has a diagnosis for, the code for a broken leg, and the procedure that you did for it was you set the bone and put a cast on it, that's going to go immediately to a computer system at the insurance company, which is going to just do an automatic check between the diagnosis code and the procedure codes to make sure everything matches up. If everything matches up, then they'll send the payment and they'll send the explanation of benefits. If there's a mismatch, right? So if it says the person came with a broken leg and what you did was you took out their lung, the computer's going to spit that out and say, no, this is a fraudulent claim, and so we're not going to pay anything on it. And this is the mindset that the insurance companies are coming from. They're trying to avoid fraud, and to do that, they're being kind of as rigorous as possible. Now, the problem is because the system isn't set up to accommodate trans people or to really understand that trans people exist, a lot of the routine care that trans people need ends up looking to a computer like it's fraud. So this is why it's really important to understand kind of what is going on behind the scenes and to advocate for your patients as much as you can. There are some wonderful resources that can help you do this. One is called Transline, which is an e-consultation service for medical providers to talk to other medical providers or mental health providers about any aspect of trans care. So if you're brand new to working with trans clients and you don't know, the ABCs, they can help you there. If you have been working with trans patients for 10 years and you have a particularly complicated case and you're not sure how much to lower the hormone dose based on what the labs came back as, they can handle that kind of level of complexity as well. So I highly recommend that as a resource for you. And it can also help you with things like, I got this denial for my patient and I don't know what to do. Someone asked, is there a website for Transline? Yes. If you just Google Transline consultation, it should come up. The web address is transline.zendesk.com. I know that we are over time already, so I will be happy to wrap up here and happy to be a resource for folks if you have more questions. I actually said that part already, so I will pass it back to you, Ryan.
Thank you, Anand. I would like to thank everyone for participating and all of our wonderful presenters. I think a lot of this information is needed. So thank you so much for presenting. You can contact me at Ryan, R-Y-A-N, at healthlgbt.org. And I also highly encourage those of you who are not already a part of the National Coalition for LGBT Health to join the coalition at www.healthlgbt.org or by contacting me at ryan@healthlgbt.org. Membership is free and open to all individuals, from consumers and patients to healthcare providers and organizations. And how to obtain CME credit for today's activity. I am going to send this out as an announcement. And as a reminder, this is available for one AMA PRA Category 1 credit. And if you have any questions or you need the information again, please feel free to contact me at ryan@healthlgbt.org. And thank you so much again for your participation and to all of our wonderful presenters.